we are going to start cornea part 11, and in this part we are going to study about the protozoan keratitis and helminthic keratitis. So protozoa in this topic includes acanthamoeba, and let's get started. Acanthamoeba. Acanthamoeba species are ubiquitous free-living protozoa commonly found in soil, fresh and brackish water, and the upper respiratory tract. The cystic form is highly resilient. Under appropriate environmental conditions, the cysts turn into trophozoite with tissue penetration and destruction. In developed countries, acanthamoeba keratitis is most frequently associated with contact lens wear, especially if the tap water is used for rinsing. So let's get started. Acanthamoeba is basically, what is it? A protozoa. And what the protozoa is, that it has a cystic form. When a cystic form is very resistant, and when the appropriate conditions are for the cyst, it is converted into trophozoite, and which causes the tissue destruction and tissue penetration. It is very commonly found in soil, fresh and brackish water. So person usually give a history of a contact lens wear, and especially when it is rinsed with the tap water. Diagnosis. The condition is often diagnosed initially as herpes simplex keratitis with more advanced signs, and the condition should be distinguished from the fungal keratitis. So its differential diagnoses include herpes simplex keratitis and fungal keratitis. Symptoms: blurred vision and discomfort. Pain is often severe and characteristically disproportionate to the signs. So this line very important, because the clinical signs are not very much, but the patient complains of a very severe pain. So it is disproportionate to the clinical signs. So what are the signs? In early disease, the epithelial surface is irregular and grayish. So let's see figures 7.24a and b for that. So 7.24a shows the initial stages signs of acanthamoeba keratitis. A is cyst. You can see the cyst in a corneal biopsy. And B is showing the grayish early epithelial involvement. So this is the grayish changes of the epithelium. And C is showing the focal anterior stromal infiltrate, and D is showing the radial perineuritis. So this is a focal, this is a deep stromal infiltrate, and this is a focal radial perineuritis. We will discuss what is a radial perineuritis in the coming lecture. Epithelial pseudodendrites resembling herpetic lesion may form. So epithelial changes are what? First it turn gray, and there may be the pseudodendrite formation, just like the herpes zoster. Limbitis with diffuse or focal anterior stromal infiltrates. So next, when the disease progresses, there is a limbitis. Limbitis means that there will be the circumciliary congestion of the limbus, and there can be a anterior segment stromal infiltrate. Characteristically, perineural infiltrate, radial keratoneuritis are seen during the first few weeks and are virtually pathognomonic. So these are the pathognomonic signs of the acanthamoeba. So what is a radial perineuritis? So radial perineuritis is basically there is a nerve supply to the cornea. So when the corneal nerves become the radial corneal nerves become inflamed, it gives a characteristic signs of the radiation, and this is called the radial paraneuritis, keratoneuritis, and it is a pathognomonic for the acanthamoeba. Gradual enlargement and coalescence of infiltrate to form a ring abscess. So basically it also form a ring shape abscess. So whenever there is a ring shape abscess, you can always make in mind a pseudomonas. You can The differential diagnoses are the pseudomonas, fungal keratitis, and acanth amoeba for that. Scleritis may develop and is generally reactive rather an extension of an infection. So scleritis can also develop in this case slowly progressive stromal opacification and vascularization. So it is when the cornea is involved, then there is another stage in which the stroma is becoming opacified and vascularized. Corneal may or melting may occur at any stage when there is a stromal disease. The melt often develop at the periphery of the area of the infiltrate. So melting usually develop in the periphery. So what are the investigations of acanth amoeba? Staining of the corneal species using periodic skiff and calcofluor white, a fluorescent dye with an affinity to amoebic cyst and fungi. Gram and Giemsa stain may also demonstrate similar. So very important for acanth amoeba, what are the stains and the culture being used? So the stain being used as a PAS plus calcofluor white. So what is calcofluor white? We discussed previously that calcofluor white is basically a fluorescent dye which takes up by the cyst, and when the cyst takes up, we observe it under the fluorescence light. And culture is the non-nutrient agar with the Escherichia coli. Non-nutrient agar is treated with Escherichia coli which trophocyte consume. So very important that the calcofluor white stain cyst and culture stain trophocyte. Other investigations include immunohistochemistry, PCR, and in vivo confocal microscopy. Corneal biopsy may be necessary for diagnosis. Now, what are the treatment? It is important to maintain the high index of suspicion for acanth amoeba in any patient with a limited response to antibacterial therapy. So whenever the patient does not respond to antibacterial therapy, one must consider about the acanth amoeba. The outcome is very much better if the treatment is started early. So what have the treatment was? Debridement of the involved epithelium is believed to be helpful as may facilitate in eye drop penetration. So it is generally true for the fungal keratitis as well, that we debride the epithelium so that the topical topical antibiotics or topical treatment penetrate better. Topical amoebicide. So amoebicide, acanth amoeba cells are resistant to most antimicrobial agent, and although successful outcomes has been reported using a variety of a topical preparation, it is likely some of the these are active only against the trophocyte stage. So cysts are very resistant to treatment. Trophocytes somewhat can respond to the treatment. So very important of this is a PHMB and chlorhexidine. Chlorhexidine is usually we make it from the mouthwash. Whenever you have a suspected of acanth amoeba, we make chlorhexidine from the mouthwash. Polyhexamethyl biguanide 0.02% and chlorhexidine kill trophocyte and are cysticidal as well. So this is the treatment. Hexamidine or propamidine, proline, the former probably has a greater activity. So proline has so hexamidine has a greater activity than proline. Voriconazole and other azole antifungals may be effective. An optical regime has not been established. So usually it is given as a duotherapy. Duotherapy, PHMB, we give biguanides or chlorhexidine or chlorhexidine plus hexamidine or proline. Examples include PHMB as duotherapy with chlorhexidine or either of these in combination with hexamidine or propanidine. An installation is orally at first and then gradually reduced. A clear response may take 2 weeks. Simultaneous antibacterial treatment for co-infection may be considered if the clinical picture suggests this. Relapses are common as treatment is tapered, and it may be necessary to continue treatment for many months. So this treatment is usually continued for many months. Topical steroids should be avoided if possible, although low dose therapy delayed for at least 2 weeks after starting antiemetic treatment may be useful for persistent inflammation. Amicidal treatment should be continued in concert with the and for several weeks after steroid. So basically, steroids are only used when the epithelium is healed and there is a response to the treatment. And also, after 2 weeks, we started when there is a persistent or severe inflammation. Pain control is with the oral non-steroidal anti-inflammatory agents like brufen, and therapeutic keratoplasty may be necessary for resistant cases including perforation. Late scarring may also require penetrating keratoplasty. Acanthamoeba infection of the cornea result in pain that is often severe and disproportionate to the clinical sign. So let's see about this advanced acanthamoeba keratitis. A is progression of infiltration with incipient formation of a ring abscess and early melting. B is showing us the ring abscess, classic ring abscess, and C is showing the melting of the cornea. Helminthic keratitis. Helminthic keratitis, onchocerciasis, river blindness is discussed in chapter 12. So basically it is causing the uveitis. Keratitis is a common feature. So that's it for the cornea part 11. See you in the next video.